Good afternoon. I'm here to present our prospective study on small aperture IOLs in previous refractive patients. So as Dr. Becker said, there are three mechanisms for EDOF. Number one, refractive bifocal segment. Number two, change the spherical aberration in the middle. And number three, pinhole. So this is the pinhole optics. So I'm a consultant for both AkiFocus and investigator for Bosch and Lomb, which bought the AkiFocus company, which makes this small aperture IOL. So there's an increased need for a versatile IOL, just like what we want. We want one IOL for all, but unfortunately, that's not possible. So in our case, we use it on normal corneas. We have patients who had a previous corneal inlay. So if you remember the history of presbyopia correction, there was a time in the early 2010, 2012 that people were putting corneal inlays. And then there are patients now who had previous RK, LASIK. So what do we do with these patients? So these patients have corneal aberration. So as Dr. Becker's population is those we have compromised in the posterior segment. These are the retina, the glaucoma. This one is the compromise is in the cornea. So those are two different usages for two different populations. So we cannot use the pinhole on the compromised retina because it's pinhole. If the defect is in the center, no use. Whereas you cannot use the segmental if it's a compromised cornea because you will get more aberration. So it's two different population targets. So the IC8, it's called an Apthera IOL, and it has two main functions. Number one is the pinhole effect masks the aberrations of the cornea. So the pinhole negates most of the aberrations of the cornea, and the second effect is presbyopia correction by EDOF. So now we have patients who had post-LASIK, post-RK, that's fine. You see all of that. But those of us who have put inlays in the cornea 10 years, 15 years later, now they have cataract. What do we do with them? Option one, just do the cataract surgery, leave the inlay in the eye, and put a monofocal IOL. Option two, which is in this study, we remove the inlay, wait 3 months for corneal stability, measure the IOL power, and then do the cataract surgery and put the IC8 pinhole inlay. So from last count, there were 30,000 eyes with this AkiFocus corneal inlay. So they will be coming, some of them will come into you. So what do we do with these patients? So this is an RKI. This is what it looks like. It looks like your new smaller pupil behind the pupil. So this is what it looks like undilated, and this is what it looks like dilated. So initially, we did a scleral tunnel because we didn't want to fold the IOL, but now we have injectors. So these two groups, one is the post-refractive, which is previous RK and LASIK. Two is post-inlay. So refractive targeting was minus 0.75 diopters. So that's the refractive target of the IC8 small aperture, not plano. Okay? So we did the study, 12 months follow-up on them. And as you can see here on the left is uncorrected visual acuity of the post-refractive eyes because of the pinhole effect. Distance vision, the blue is the IC8, 0.4, 0.04, 0.09. So 2025, 2025, 2025. Distance correction is about 2020, 2025, 2025. So that's the usual result as long as you're on target. So our MRSE on the bottom right is about minus 0.55 diopters. So be more minus. If you want to use this lens, it's better to be more minus than plus. You see that the focus curve is wide and equal in both sides. All other EDOFs are one side steep and one side like that. This is equal because it's pinhole. So it's an equal like a symmetrical Mount Fuji. Okay? Mesopic, everybody worries that it's dark. It's dark for patients. But on-label approach is one eye, non-dominant eye. The only problem you will have is post-RK because two eyes have RK. So now you need two eyes, but all the rest is one eye, the non-dominant eye, and the dominant eye use your standard monofocal or EDOF lens. So in terms of post-inlay, same results, 2025, 2025, and 2030 uncorrected. That's the most common outcomes in these small aperture eyes. And of course, binocular, the distance is better because the other eye has a monofocal for distance. Again, the focus curve is it looks flat because it's small aperture, no? 2.5 diopters. It's not J1. That's why it's EDOF because the optics cannot give you J1. But again, with mesopic contrast sensitivity, there is a 2 decibel drop in contrast sensitivity measured by visual field. So yes, it is slightly darker, but not too obvious. So visual symptoms, because it's pinhole, there's not much glare because the pinhole filters glare, filters aberrations, but there is some halo effect which some patients notice when driving at night. So in terms of 1-year outcomes, so far so good. Most patients, almost all patients have this continuous range of vision like EDOF, increased depth of focus, monofocal-like contrast sensitivity, and low levels of visual disturbance, but it is something for you to use in your aberrated corneas and maybe in your normal corneas as well. So it's one of the options that we have now, the small aperture IOL. Thank you. Sorry, are there questions? Sorry. Yes, Harms. There is no minimum pupil size. There is a minimum dilated pupil size. You need to be able to dilate your pupil at least 6 millimeters before you use it. Not a small pupil, but a big pupil, because you need to check the retina after. And when you dilate, we check outside the mask. So the black mask is 3.4 millimeters. So you need to be able to check the retina. It's for the retina checking. But the small aperture inside is 1.3. So it's like a small pupil. Any other questions? So very useful. So now you have representation, and one more from the next speaker, representation of all the EDOF